Hi, good afternoon, everyone. Rich, you can now broadcast to Docwitty, please. Okay. Thank you for coming on a Saturday afternoon. I know all my webinars are all on Wednesday, but the only way I could get Dr. Amar to come is because he only do weekends. He sleeps early. He's a very, very disciplined person and adherent to a very healthy lifestyle, and a very, very difficult person to get to speak for anyone because he's so extremely busy. Thank you so much. Today, actually, he has spoken for me from a few topics, I think, and one of it was really amazing, the X-ray on neonatal, neonates and pediatric. But today we are also going to speak on children because, as you know, Dr. Amar is a pediatrician by training. He was the head of department in Ipoh, right? Currently retired and doing a lot of work on both children, public health, and actually social, and also thinking how to change the thinking of society. So without further ado, we invite Dr. Amar. Okay, Amar, go ahead.
Thanks, Betty, and good afternoon, everyone, and good evening. Thank you for being here. And actually, I do speak on weekends as well, but Betty, I don't speak at night. That's one of the rules. So yeah, weekdays, sorry, yeah. So, but most people are working at that time, so it's a bit tricky. Yeah? And as Betty says, thank you very much for making time this afternoon. The first thing I'm going to start off is I'm going to post some resources in the chat group. And Betty, you may have to repost them because people who come late don't see earlier messages.
Oh, is it?
Yeah,
okay, I will.
So I've just done that right now, and allow me to share a screen, and then let's get from there. Huh? Betty, can see the screen?
Yes, that's right.
Okay, fine. So Betty's asked me to talk about current challenges in child health, and I'm going to talk about unmet needs in our country and how we can work to improve our health services. I'm going to give you a very broad view, maybe a perspective you're not familiar with. Huh? I often use this slide to introduce myself. This is a picture of me drawn by children. I have quite a number, but I like this particular one because he captured my long nose very well. You know, this long nose of mine here. He's captured my hairy arms very creatively. My lovely eyelashes as well, you know, done there. So I'd like to speak today from the many decades of working with children. I'd like to speak from their perspective. I've learned a lot from children, both from children in the community as well as children I've seen in hospital and clinics. And I want to share from them what their perspective is. I start off by this statement that I make quite often. I speak to you from the First Nation of the Orang Asli people of Malaysia, in whose land I live. And why do I speak like this? Because this is their land, and we have not adequately respected their thing. If you go to Australia, you go to Canada, this is how people will talk about the original people of their land. I like to talk about them in that way as well. I've given you a couple of links. The first link is the one that you want. Don't ask me for slides, but take the documents, which are more valuable. In that link, there are 4 documents, the first link. One is a document I wrote about why children need to achieve the Sustainable Development Goal. And I wrote that for the Royal College of Pediatrics and Child Health in the UK. And it's very extensive. There are about 30 pages there. The last 2 pages will cover this talk extensively, clearly, but the rest of the document covers as well. I wrote one for the Medical Legal Society of Malaysia just this year on talking about access to child health. You may find that very useful. I just put out a letter. I put out a letter today on how we can change our healthcare, and there's a link inside there. But there's a letter to the press on World Children's Day, and there's a COVID impact, all documents that may be valuable for you. You can scan this QR code, which will appear again in a moment, but the link is in the chat box. So I'm going to talk about our changing healthcare challenges, and then I'm going to talk about 6 key challenges, 6 plus 1. Why do I talk plus 1? Because that plus 1 is so huge, it will engulf everything else, and we have to talk about it in a special focus. And I'm going to make suggestions for each challenge and how we can move forward. Now, I've got a lot to cover, and so I'm going to skip slides, so don't worry about me skipping slides. Try and get the focus of what I'm saying. I like this quote from one of my sifus. It's Merton, who's a Trappist monk. And Merton says, people spend their whole lives climbing the ladder of success, only to find once they reach the top, the ladder is leaning against the wrong wall. And this is the very big danger of our healthcare services when we put them for children. If we aim our healthcare services against the wrong wall, when we reach the top, we will find we're at the wrong place. And currently, we're leaning against disease. Disease is the wrong focus for healthcare. If you want healthcare, you've got to focus on health, not on disease. I often talk about Ministry of Health as a Ministry of Disease rather than Ministry of Health. Okay. So we're changing, and this is a cartoon from LUT, which shows how we're changing. This is an old cartoon, but it shows how, you know, mom has to change her feeding strategy. I think in my day, you get 2 tight slaps and eat your food when you don't want to eat. And today we play with handphones and aeroplane and stuff just to get the children to eat. And it shows how rapidly our society and our healthcare needs are changing. The problem is organizations and healthcare professionals don't change fast enough to meet these current challenges. So we're still stuck with some old challenges in terms of mortality and vaccine preventable diseases, but we move very rapidly into lifestyle, healthcare delivery problems, genetic conditions, environmental problems, urbanization. So we move from mortality to morbidity to what I call new morbidities. And now we may be moving to new mortalities with COVID and other challenges. So just one very quick set of data. This looks at under 5 mortality, the dark black line, and you can see we have done very well. I've been very heavily involved in this, but you can see we have stagnated for the last 20 years. There's been almost no change in our under 5 mortality in the last 20 years, and that tells you we are not addressing today's health challenges for our children. Looking at the countries in our region, we don't look too bad. Of course, you can look, Singapore is dramatically better than us. But I haven't put in here the countries I like to put in, Taiwan and South Korea, which are far ahead of us. They 30, 40 years ago, they were behind us. Today, they are far ahead of us. So we look okay on the national scheme of things, both for our neonatal and under 5 mortality, but we're not really okay on the ground. Okay. I want to tell you, very important, that health is very much linked to money. And this is a log scale showing, child mortality versus GDP, our country's wealth, and you can see this clear line. More importantly, how much we spend on health influences healthcare, and you can see these 2 countries that I mentioned spend an enormous amount of healthcare, more than us, which is why they're doing so well in their healthcare compared to us, Australia as well. Okay, so I'm going to talk about the current challenges and the emerging ones and the potential ones to come. The key weakness in Malaysia is that we don't get data shared with us that is disaggregated. To really understand health needs in Malaysia, you need disaggregated health determinant data, which means by income, by residence, by gender, by different ethnic groups and so on. And this data often is not shared with us, so harder to figure out data. So let's talk about what you came here for. Number 1 is the people that I think a lot about, which are the indigenous and rural communities, especially the indigenous communities. I'm talking about Orang Asli and Penang, and especially the rural Sabah communities. These are 3 very poorly served communities. Their mortality rates are enormous compared to the rest of us, and I consider this a silent genocide of our people. Here's a age-specific under 5 mortality work done by Hang Maria and me put together. And you look at, this is the national average, and this is the Sarawak indigenous, Sarawak and Sabah indigenous. So you can see they're almost 2 times our mortality. That means for every 1 Malay, Chinese, Indian that die, 2 Sabahans and Sarawakans die. And then look at Orang Asli, it's 11 times. And this is not finished yet. A lot of them is tanam dalam hutan. We don't really know their deaths. My work with Orang Asli over many decades, I estimate it's probably 15 times the national average. And look at what we're doing to our immigrants. The Indonesian and Myanmar children have a 25 times mortality compared to the national average. I've done a study for KKM, and 50% of all these deaths are preventable. And so you can imagine the impact we could if we dealt with this community. And so this is the kind of children that I've dealt with almost all my life working in Perak. I've got permission to share this from the parents. That's Faisal, he's got kwashiorkor, and that's Rose Maria, who comes from Gua Musang area over to Perak for treatment, and she's got marasmus. And we see a lot of this kind of children because that's what's happening to these Orang Asli communities. I did not see this when I was young. In the 1980s, I did not see malnutrition Orang Aslis. Today we have. We call this the inverse care law. That means the people who need healthcare the most are not getting it. And why has it happened to Orang Asli? It's entirely social political. We've pushed them into the interior. We've taken over their land. We've locked it. We've polluted their rivers. They've lost their protein source, which is the wild boar, deer, and the fish. And we relocated them to camps, which are deaf camps, actually, because they live in the forest. The forest is their supermarket. And so there's an enormous mortality. So I want to show something I missed it. Okay, here's one study I've just done looking at all under 2 children in Perak that we can access to, and 41% are malnourished right now. Despite all the work we have done, 41% at 2. And 40% don't have their growth chart plotted adequately for us to check. So people are not even bothered to plot their growth chart of these Orang Asli children. So we cannot assess another 40%. So this figure is a very conservative figure.
And this is actually happening real time.
Real time right now. And we are in the best state, Perak. We are most perhatian about Orang Asli because a couple of us are working very hard with them. So what can you do with these communities, the Orang Aslis, the Penang and the interior Sabah? You need refeeding programs. This is a firefighting program where you actually give them a feed. Every child under 5, you give them 1 protein-rich meal every day. And the second thing you need to do is have community-trained healthcare workers. These people have little access to health. You need their own people to know what to do and when to call us. Of course, we need to revamp our organizations working with them. And finally, long-term, we need developmental work that, uplift the community, not charity work. Careful that medical camps can be very harmful, can make these people beggars rather than help them. I'm not enamored by medical camps. I wrote a document over many years, and in 2010, I shared it with our health minister. He was appalled at the situation. And for that reason, we now have access to the healthcare of Orang Aslis, moved from Jaguar over to KKM. And so we have better able to support them. And so we're doing this kind of thing in Perak. We are refeeding them. We get money from corporate bodies and from government to try and feed them. And the impact is enormous. Mortality dropped by 90%, admissions dropped by 50%, malnutrition dropped by 41%, even though I quote so high, but still we brought the malnutrition rates down considerably, safe delivery and so on. So there are measures to deal with them, but it requires funding. The problem is this kind of mismatch in our country. I sometimes say 1 pillar in Putrajaya can feed 1 kampung Orang Asli, for a couple of years. But we don't seem to see that. We still keep building these unnecessary buildings. In case you think there's no money, here's 2.3 billion ringgit spent on the River of Life project in KL. But they're not willing to spend 6 million ringgit a year to feed all the under 5 Orang Asli in the country. So we have to beg for this money every year. So there is a lot of money in the country, but it's not going to where we need for this community. So that's the first community, which is Orang Asli Penang, rural Sabah. The second group are the poorly reached urban populations. 78% of our population now lives in the cities, 30% in slums, and 25% of our under 5 deaths are related to pollution, including in Malaysia. This is a UNICEF WHO data, not mine. And so we have this rapid urbanization, and now peaked at about 78, probably will reach about 80% urban. And they have got problems here. Living environment, the economic conditions are poor, they're paid very poorly. And I'm using this word migrant here when I mean both people who have come from overseas, but also Malaysians who have moved from rural areas where they had better conditions actually, somewhat, they can grow something, to an urban area where they have no land to grow anything. And of course, many of the children end up with lower educational attainment, poor nutrition status. Very, very good study from UNICEF showing stunting in the inner city is very severe in our country, more severe than our neighbors. Very poor housing, okay, and often abuse. Fortunately, recently, because of all the push by many individuals, we have moved our poverty line from this ridiculous number to this number of 2,280, which is not enough yet. And we now have a poverty rate of 2.8% compared to something like 2% previously. But notice the poverty rate in Japan is 15%. And Japan is not poorer than us. They have a more decent poverty rate than we have. So baseline, we have 2 million children living in poverty right now. But nastily, COVID has pushed another 2 to 3 million children into poverty right now. This is data from Merdeka Center, and that was in 2020. I'm not sure what it looks like. Since then, it's probably got even worse. So I call this situation, this urban situation, the Moloch and the Eloy kind of a situation. The Moloch has served the Eloy. If you ever read H.G. Wells, I'm a science fiction and fantasy fan. There's a time machine story he wrote where if you go into the future, civilization is shifted into 2 groups, the Eloy and the Molochs. The Eloy live on the surface in ease and the Molochs serve them. And quite often I believe this is what happens in our cities. The poor serve the rest of us who have money, and we need to reverse this kind of social structure that we're developing. So there are a lot of urban healthcare risks for them, more than for us, because they live in poorer conditions, air pollution, unsafe water, even in Malaysia, increased suicide risk, a sedentary lifestyle for them because no green lung, higher risk of road injuries, and of course, the impact in climate change. What we need, of course, if you want to help, that means to revise our poverty line to 3,000 minimum. This will make 30% of Malaysians then poor. At least we can start addressing that. If you don't recognize they're poor, then you don't get resources for them. We need mobile health delivery systems in the urban centers. You cannot wait for them to come to your clinic. You need a bus delivery system where you go out with your ultrasound, your drugs, your pharmacist, your nurse, and your records, and you go and deliver system to them. We need some proper services for our migrants and not think of them as just people who are serving us. We need to really invest in low-cost housing, good housing for the low-cost, for the low-income groups. And finally, we need a national agenda to reduce vehicular pollution. I'll talk about this when I talk about the last issue here. Number 3. So first, indigenous and poor Sabah. Number 2 is interior, urban, slum poor. The third one is unintentional injuries. And you may not recognize this as a health problem in Malaysia. Definitely, a lot of people don't. I've done a lot of work, and this is available in publications, both on road safety and on drowning. And 900 children plus die on the road every year, and 500 plus drown every year. By the way, 700 adults drown every year, and about 3,000 adults die on the road every year. So it's a huge health problem. I once did a study for MOH, asking them what are the commonest health problems for children aged 1 to 18. And surprisingly, majority of the healthcare managers in MOH could not tell me this problem, which is road and drowning. They told me things like dengue. So let me show you the data. This is under 5 data, which MOH knows very well. The commonest cause of death in children under 5 is prematurity, then congenital maladies, then infection, then injuries, and then malnutrition, then cancer. But if you remove the first year of life and we focus just on 1st to 18, then injuries becomes number 1. It's huge. It's 60%. It's road or drowning, and then infection, then cancer, then others. So this kind of data representation doesn't seem to get across to our managers. And so I often show this kind of a slide to try and jog people. No disease kills our children like road and drowning. And we need to think about it that way. For 1 child dies of dengue, and dengue is very much in the consciousness of our public. 1 child that dies of dengue, 30 will die on the road and 10 will die of drowning. But this kind of numbers don't seem to translate even to MOH. MOH has spent hundreds of millions of dollars on dengue prevention, probably not even R1 million on road, and not even 100,000 on drowning prevention, even though that these two are huge mortality problems for our children. So I want to emphasize that this is a grossly underserved area, and I hope that some of you who are listening, who are medical professionals or even not, would think that you want to become a specialist in injury prevention. Don't become a cardiologist like Betty. Don't become a pediatrician like Amar, but become a person who is a specialist in injury prevention, and you might save more people in this era than ever before than anybody else.
But can I stop you here?
Sure.
Okay, you know what is very important here? The road traffic accident, especially when another person is jailed for it. Okay, the incident, right, just shows us that this is not just preventable, but we not only have to prevent it, we have to educate parents on how to bring up children.
Yeah, I agree with you, but that there are many facets to it. As I said, we have about 1,000 children who die. I want to also point out that 4 times as many get disabled. So for every 1 adult or child who dies, there are 4 times as many who get permanently disabled, lost a limb, spinal injury, CNS injury. And when you think about it, there's a girl who was in a mass bus event that I helped to manage. I've done lots of injury studies. I'm not going to share the data completely with you, just a little bit to show that these are thousands of children coming to school on motorbike, no helmet in about 40%. Of those who wear helmet, also no chin strap in many of them. So simple things like this that we need to work on. No car seat studies and so on. For drowning, I want to tell you that 1/4 of our drowning is in swimming pools and theme parks. Do you know that? 1/4 of our drowning is in this kind of environment where there may be a lifeguard spotting the person, or especially in Port Dickson, in the swimming pools. That's a very dangerous place, actually. Okay. And a lot of our drowning is also due to the fact that children jump in to save children. We can halve our drowning rate if we just give this message, children, don't you jump in, you call for adult for help to save them. So I want to say there are many initiatives, and I can talk about injuries for 2, 3 hours. I have lots of data, but I want to say that for injuries, the simple things we can do: make a car seat mandatory. And the way to make it mandatory is to force all vehicle salespersons, Toyota and Proton and all the others, to give a free car seat. They make a lot of money out of us. Even to Proton, give us a free car seat with every car as a free accessory. That's one quick way to do it. We need an electrical bus public transport system. That's the only way to get rid of motorbikes. Motorbikes cause half our road injuries. And there's no way to make motorbikes safe, but affordable, extensive public, if you have 100,000 electrical buses in Klang Valley, I can tell you, you can remove 80% of your cars. It means we don't drive anymore, by the way. Huh? LRTs don't cut it. Let me tell you that they're too expensive and they feed the wrong people. They're put there to earn money for some people. Drowning awareness, I agree with you, Betty. We need that. It must come into the psyche of the average Malaysian. And I haven't mentioned poisoning, but we need to dispense our medication in child-proof containers, blister packs or child-proof containers that don't poison children. A lot of children, 25,000 get poisoned every year.
Really?
Yep. So it's another issue. Not that many deaths, but they get poisoned with simple things like mother's oral contraceptives, grandfather's antihypertensive pills, which can be very dangerous for a young child.
Even paracetamol.
Of course, paracetamol can kill. So that's unintentional injuries, which are a huge health problem. The fourth one is it's a crisis and it's going to go and get worse in many different ways. The lifestyle-related adult illnesses with onset in childhood and behavioral problems. So this is related to sedentary lifestyle and obesity. 1 in 3 children are now obese. Screen addiction, which is now universal, including all of you who are listening in. Mental health problems with increased suicide and gender confusion. And of course, smoking and substance abuse, which is fairly significant in our children. Here's a study I did about screen use in 2-year-olds. And they use, this was in 2016, and 6 hours is the average screen time for a 2-year-old in Malaysia.
So, yeah, that's a lot.
That's 2016. I can tell you that if you take enough screen time history from everybody, you will find it's 8 hours that's happening right now. Huh? Okay. And this is the average Malaysian family. I'm sure many of you go out to eat, and this is what we see. Huh? Adolescent internet addiction from the NHS National Health Mobility Survey study is 38%. And prevalence of obesity is 20% right now in children. I've done lots of studies on this, and it's a study on play, and 66% of parents want their children to play indoors because they say it is safer. So that's not a good place to play. You want them to play outside. The problem of playing outside is there's no place to play. This is KL, open land for recreation, 6.5%. It's just too small. You need a lot of play areas and safe play areas for children to play. Then only parents will take the children out. Okay. Here's from NHMS study 2017 for adolescents 10 to 17. 1 in 10 currently use alcohol, 1 in 5 smoke, especially boys. 1 in 25 have used drugs, 3 to 4% currently on drugs, and 7 to 10% have sex. So these are lifestyle problems that will go on into adulthood to have major problems. Drug addiction, long-term smoking damage, sex-related problems like teenage pregnancy, and of course, other diseases that come with them. Okay. Here's also from that same study showing that for Form 1 students, 10% have said they attempted suicide, 11% have suicide ideation. Suicide is a very important risk. These last 2 years, we've seen a huge rise in teenage suicide in Malaysia due to COVID problems. And this is our adult profile today. I call it the 1 in 3 adults. 1 in 3 overweight, obese, 1 in 3 hypertensive, 1 in 3 diabetic, 1 in 5 asthma, chronic respiratory, 1 in 5 coronary disease, 1 in 3 allergies, and 1 in 4 will get the big cancer, big C. Huh? So this is the profile of Malaysian adults, which doesn't have to happen. These are all preventable if you work with children to reverse what's happening with them. Okay. So how to reverse it? There are no quick fixes. I think one of the key things is that all clinicians, all specialists in hospitals should work 40% of their time outside the hospital to work on prevention rather than just work on disease. And I think we need to promote safe green spaces and recreation of all of us, not just children, adults, and 15% of all total land space must be dedicated to recreational space. We need a national campaign to move all of us away from our screens, and that's linked to number 1, of course. We need, of course, I recommend that you do obesity screening by the age of 2 in children to pick up obesity early. But the key is this: a bus rapid transport system, electrical bus rapid transport system with last mile walking and cycling. If you go to Netherlands, for example, you won't drive a car. You will use this. You'll use some LRT, but you use a lot of bus transport. You will cycle, and walking within 6 weeks to 8 weeks, your life is not the same anymore. You're extremely fit. The obesity rates are very low there. Cardiac problems are very low there as well. So I think we have to change the structure of our cities if we want to do something here. And of course, this is coming. And this worries me quite a bit as to what this will happen with virtual reality. I'm not against screens. I use screens a lot. I just want children to find balance with them. Number 5 is disability and genetic disorders. And 15% of the community comprise children with disability. We have an autism epidemic growing in the country. Currently, 1% of all children, especially boys, is estimated this epidemic might peak at about 5% of all children in the world. We also have a speech delay epidemic. I would say now 20-30% of all children in the country have speech delay, partly due to excessive screen time. And of course, our services are very limited. These are friends of mine. He's got a spinal muscular atrophy, doing very well because of cutting edge treatment that the parents are advocating for. Okay, so here's a quick graph showing where that disability is. The US CDC quotes 1 in 6 children, even higher than I quote. I quote 10 to 15%, 10% probably in early childhood, 15% by the time you reach school-going area. And I'm not talking about those physical or sensory problems. I'm talking about these intellectual disabilities, attention deficit hyperactivity disorder, autism, and specific learning disorders like dyslexia and dyscalculia and so on. And I don't think medical school prepares any doctors for this, doesn't train them at all about this. So they have difficulty managing or recognizing this. We need a lot of services, and I'm not going to go through the services here, except to summarize in this format. I've been working for a long time. I've been working with disabilities in 1978. And I want to say that we've been working a lot first with diagnosis assessment. It's got better, except for rural areas. We then worked a lot with preschool areas. I've started many NGOs, and there are a lot of NGOs in the country now providing preschool support for parents to prepare them for school. School is not good. We are far behind other countries. I wrote a paper for APEC, Asia Pacific Economic Cooperation, talking about our failure to have inclusive education for our children. Employment, we're dismal, and long-term care, we're very poor. So we still got a long journey to go for the services for our children with disability. I'm going to skip all this. Let's skip all that, don't worry. I want to show you that data from MOE, Ministry of Education, that for the children who enroll with us in the Ministry of Education schools, 43% are having problem reading and writing. And after remedial support of 3 months, 10% are still struggling. So you can see this is the volume of disability I'm talking about. It's not just taken from international work, but from our local work as well. I also want to point out that 30,000 to 60,000, we don't really know the real number right now, are not in MOE schools. They are in religious schools, they are in home schools, they are in private or private or international schools, and we don't really know what's happening to children in those schools. Okay. I've done quite a number of studies. Here's a study done with parents. Interestingly, I like to do study with the community, talking about our inclusive education experience. If any of you want any of these things, just ask me and I'm happy to email reports to you. This study showed that of those parents who tried, these are people with children with disability who tried, they put their child in mainstream school, only 41% were successful, and they were more successful in the international homeschool or private school. They were least successful if they were in the Ministry of Education schools, which is sad. Let's skip all this. All right. So what works? I've written quite a few documents. I just wrote a landmark document for the future for services for the disabled. And we need to expand our preschool services throughout the country. And this has to be government funded. We cannot continue asking NGOs to fund this. And during COVID, 25% of all our preschool services shut down. 25% of all kindergartens and NGO services shut down during COVID because no money, no gaji. Huh? So we need to, I've been pushing MOH to, pushing government to come back. I presented a paper on education to the National Recovery Council, chaired by our ministers, to part fund all these services for our children. Huh? Secondly, we need transdisciplinary therapists. We focus a lot on physio, occupational therapists, special education teacher, but we don't have the luxury in Malaysia for this. They're not enough. The speech therapists hardly can provide speech therapy services. So a long time ago in 1991, I wrote a paper for MOH that we need transdisciplinary therapists, somebody who can do the whole job. They're part physio, part occupational therapists, part special ed, part psychologists, part behavior therapists. And that's the kind of people we should train. And finally, we need a true inclusive policy. For you, if you're a medical trained person, please advocate for your university to please have a better curriculum on special education needs instead of 1 or 2 hours in 5 years. Okay. I don't know where you are with your disability situation, but this is how we are talking about disability. We don't talk about disability like this lousy, useless symbol. We're talking about this new symbol, talking about people with disability have talents, they have abilities, they can direct change. And, I'm dyslexic, I'm disabled as well. But there are many people I've met over the years who are phenomenal. They may be completely non-verbal, may not get out of their wheelchair, but they can use a computer-assisted devices with their using their eyelids to operate it and write a document, and are far more articulate than I am. And I think we just don't recognize this about them. So I want to
go back to oh, I love it. The next one especially.
Yeah, I didn't show the next one, but we are talking now about this. You don't have to fix people with disability. They just want support to be able to live in society better. They don't want charity. They don't want pity. They want us to empathize with them and make accommodation. What is the word that we call is reasonable accommodation. Make reasonable accommodation for us in university. Make reasonable accommodation so we can take an LRT and stuff like that. Yeah.
Because just by showing these 3 pictures, my concept of disability just changed completely. It is just so amazing, these 3 pictures. I can't thank you enough. Because, because as a person, I never put much thought into this at all. But the fact that you showed me this, it is like, yes, we have to do more. Okay, go on. Sorry, I'm just...
No problem. Yeah, now, some of us who are disability activists have launched a campaign, just launched actually this week. We've done a couple of research projects for ourselves as well as for United Nations about our situation. And we are launching a Make the Right Real campaign. That means we know the right things to do. Let's make it real. Let's not keep talking about it. Let's make it real. So we call it OKU Rights Matter. I recommend that you go to this website, which I've also posted in the chat box. Betty, at this time, maybe post all 3 links in the chat box as well. You can scan this QR code and get to there as well. Please join us in this. To advocate for inclusion of persons with disabilities, to advocate for social justice. What does this mean? When you advocate for people with disability, you're also advocating for gender, for all the women who get downtrodden in Malaysia. You're also advocating for people of different ethnicity and different religions. You're also advocating for the children and the older people who often get marginalized in society and so on. And so we ask that you post a picture of yourself or of your group, together with this, to try and get a groundswell of people to think of disability inclusion. These are our hashtags that we're using to push this forward. If you go to this website, you will see one of the latest paper on disability inclusion. It's about 40 pages long. We looked at many people in the country and their situation. There are many documents on this website. We're trying to make this website a resource place where many people can go and get the resources they need to support them. Thank you for considering joining this campaign. Okay.
Oh, that was indirectly telling people to join.
Of course. I'm promoting this, of course. Not for myself. We're hoping this campaign will have a life of its own, and Malaysians own it, not us. We don't want to own it. For that reason, we haven't asked any VIP or anybody to launch it. We just a slow ground launch moving up. And we're surprised. Some parents have picked it up and they launch with their children and say, I need more for my child with disability. But we want the people without disability to fight for the people with disability. I think that's the way. I want the Chinese individual to fight for the Malay. I want the Malay individual to fight for the Chinese. I want the Muslim to fight for the Christian to fight for the Muslim. I think that's what we want in our country, and not let
everybody fight for the 80s.
Yes, and not let the negative narrative of our politicians, pollute us.
Justice is the main aim in life.
Correct.
For anyone.
So, yeah, this campaign is trying to push us away from a charity model to a rights and social justice model. Okay, if you want the right words. So number 6, don't worry, I'm going to give you some time to ask me questions. So number 6 is unintentional injuries. Earlier on, we talked about intentional and unintentional injuries, which means child abuse. And it's a fairly high prevalence all over the world, also in Malaysia. And we have this kind of a graph in Malaysia of data. The reason I haven't used data beyond 2019 because it's totally unreliable because of COVID. But I started working here before this. And in my time, when I reported child abuse, nobody wants to even listen. They don't even want to acknowledge it. And if you look at why abuse has gone up, numbers, because of 4 children, Balasundram, Afiq, Nurhuda, and Nurin, who came out very publicly in the press, all died. This pushed our numbers up. But these are not our real numbers. This is the minimum numbers. The real numbers is between 8 and 26%. I quote 10%. Only 3 of us have done community studies, myself, Kamruddin, and Chu. And what we do community studies, we go to adults in the community, ask them anonymously through a survey, have you ever been physically or sexually abused? This is sexual abuse data, and it's about 1 in 10 at least. So 750,000 Malaysian children today are being sexually abused while we're talking. How many did we pick up? We picked up in the 2019, we picked up 1856. That's very, very small. Huh? Imagine if ever you told somebody, I picked up 0.03% of all diabetics in the country, somebody will laugh at you, kind of thing. I mean, that's a ridiculous kind of volume. So I wanted to recognize that this is a huge epidemic in our country. For physical disabilities, 25%. 1 in 4 children is hit. I'm using legal definitions of our Child Act to describe this. So hit and left a mark, a sustainable mark. Here I'm using the sexual definition from the Child Act as well.
So when you say hit and left a sustainable mark, we're talking about a physical mark, right? Not the psychological.
No.
Right?
Yeah. So for physical abuse, that's the definition. For sexual abuse, the definition is one person using a child for their own sexual gratification or the sexual gratification of another individual, which means it could be anal, vaginal, oral penetration of a boy or girl, or it could be exhibitionism, or it could be showing porn to the child, or it could be taking a picture of the child, or it could be asking the child to do something to you, or it could be actually just touching the child in a sexual manner or a sexual part of the body. So I think all these things constitute, and that's the percentage. Whenever I talk to adults, I get huge numbers telling me about their own sexual abuse history. And I want to tell you that the primary sexual abuser is in the family. It's not outside. Usually it's the father, the uncle, the brother, the grandpa, people like that. Sometimes a religious leader or a teacher. Okay.
Can I ask you something? Is it very often that you see a victim of sexual abuse being abused in the family by numerous people, but all not knowing about it?
In the study that I did, Betty, 30% were multiply abused. Father, brother, uncle, that sort of situation.
Is it because the brother, father, and uncle were
they found out? One person found out about it and then also, participated in it, not necessarily at the same time.
Oh, but is it because no? Because I've seen not many. I mean, I've heard and one I was a medical student. One girl, she was 13 and she came with a headache with the teacher, and then it turned out that eventually she broke down and she was sexually abused by quite a number of people, and she thinks that none of them know about each other.
It is possible, but there is a whole range of sexual abuse here. We have mothers who pimp out their daughters for financial gain. We have a father who sexually abused his daughter publicly in the home. Everybody knows, but nobody makes a sound about it. We have, a family member who sexually abused every single member, boy and girl in the family. So there's a range of this. Huh?
Yeah, I think we'll move on.
Yes. So the key is very difficult to deal with this, and we hardly got any sex education in our society. I want to suggest that the key initiative is a nationwide preschool and primary school training program to teach students protective sexual behavior. Don't call it sex education, teach them protective sexual behavior. What is right, what's wrong, who can touch you where, what to do if something bad happens to you. Don't keep secrets. I've written a manual for this, endorsed by the majority of the civil society NGO organizations in Malaysia, and I'm happy to give it to you to use. I've also written a section on how to train the disabled who have a higher rate of sexual abuse among them. But long term, we really must use the Child Act. And Betty has arranged for me to come back next week to talk about how to use the Child Act, how to operationalize the Child Act in full. And I'll talk a bit more about that when we come to that. So that's the 6 areas: indigenous and rural Sabah, the urban poor, unintentional injuries, lifestyle diseases, our intentional injuries, child abuse, and then here's 0, 6+1. I call it 0 because it is the biggest thing. And we as healthcare professionals or as general public or as anybody in the world right now, you need to be aware and working on this because this is going to engulf us. We see a lot of it now being talked about as opposed to when many of us were talking about it. And remember that I quote documents only from the IPCC, the International Panel on Climate Change from the UN. They are very conservative, and their conservative is frightening. So if you talk to the people who are really in the cutting edge, it's even more frightening. So we call it climate emergency. We don't call it climate change anymore. We move from concern to change, to crisis to emergency. And people now are talking about the 6th mass extinction of the species of the species of the world. And last time this man used to carry the sign, the end is near, now the end is here. I think is the more appropriate sign for this. And this is a reality. Here's World Health Organization that I quoted earlier, saying that 25% of all childhood deaths are due to this, and especially air pollution, which is the problem. And here's Ipoh. This is taken from a hill nearby, Chllenges Hill, 10 o'clock, not a haze period, good period. And this I have been seeing since 1990 in my city. And it's there in most of our cities, we just ignore it. But can you imagine breathing this rubbish in and out, not just the particular material, but the chemicals that are in here, and what it's going to do to you over 30, 40 years. There is a lot of good data now showing the huge increase in deaths from low respiratory infection, chronic obstructive disease, lung cancer, stroke, and ischemic heart disease, all linked to air pollution. In fact, there's one good study from UK showing a link to suicide and air pollution as well. And so this is not something far away. And, dirty air can move from country to country. I've seen sometimes air just roll in, from different places into our country as well. So I'm coming back again to it. This is one of the major solutions to re-engineer our cities, to get more green lungs in. To get more green lungs in, you need a public transport system. The one that works is an electrical rapid bus system. Don't forget the word electrical there, which I didn't put in. Okay, this one has enormous data behind it to not just the air pollution reduction, but the health benefits to all of us. And it's not difficult to do. Sorry, let me show it here. Oh, I've missed it. Oh, I missed that slide. I apologize. I apologize.
I want to see you.
I had a slide showing what happened to Bogota and what happened to Paris. They have changed completely. And what people are doing in many cities right now, and COVID has enhanced this, is they have actually cut cars to the cities by 60 to 70%. They've taken over all the car park areas and make them parks, green lungs. But first they put in a rapid transport system and they enable walking and cycling. Like Bogota, for example, they put one whole lane, 60 km of it in the city just for cycling alone. They just cut off, they just took one lane and put non-permanent barriers and just put it. Then they put another lane in for bus and then they left the rest for the traffic jam. And of course, everybody started using the bus and cycling because it was so much more convenient. So we can do this. And don't tell me that Malaysia is too hot to cycle. It's not difficult to cycle. All we need is a lot more trees and shade. Of course, we might get wet occasionally in the rain. So why don't our government want workable strategies? There's, of course, the hidden agenda, isn't it? Large corporations drive the country. They want you to buy their cars. They want you to use their petrol. Greed and capitalism rules our governments. We know that. Not just our government, all the governments in the world for that matter, most of them. But why don't we change as a community? We know, many of us know the solutions. Why don't we have the will? But the reason for us is that we're addicted to our life support system. And what are our life support systems? Our handphones, our cars, our cities. And we are very reluctant to live. I've asked you to live without your handphone for one day. I think many of you will scream and say, no, I'm not sure I can do that. Or I've asked you to live a car for one day. Again, something that you may struggle with as well. So I consider this our collective psychosis, our denial of reality. COVID emergency is, the climate emergency is here, but we don't seem to want to touch base with that reality. So we have a collective community psychosis right now going on. So how can we all move forward? I think advocate for your own change first. My wife and I kept a mulch pile for more than 20 years. We recycled everything. We have a very, very green urban house where lots of living things come. The air is, our temperature is 2 degrees cooler than the neighborhood. We don't use an aircon at all. So first advocate for your own change that you need to do. Then I think work with Ministry of Health and other agencies. Ministry of Health is a good agency because health is a good vehicle to make change. And then influence national policy. Work with the media. The media is good. They do listen. And finally, I think we work with families and communities to empower them. I often do research, and I advocate that research is another tool that we can use because people listen to data. I like Greta Thunberg and what she's doing. I like this group called Extinction Rebellion and what they're doing to help us. And Extinction Rebellion right now is working with healthcare professionals in many countries. In the UK, the healthcare professionals have come out and in protest saying that this is a health problem, climate emergency, and we must do something about it. I want to end with this slide. I can come back to anything that you think I've done too fast or not showed you. I drew this for myself in 1991 to think about where we are. So I was thinking, this is where we are. Many of us, we are in tertiary healthcare, tertiary services, where illness, we're waiting for the man with his diabetic gangrene to turn up, the chap with hypertension to develop a stroke and then turn up, and then we will treat the person, or the child, with a pneumonia, worsened by air pollution or malnutrition and so on. Then some of you are working here in secondary care, where, we are treating chronic illnesses. Some of you here in primary care, where people are getting ill and getting sick. Not enough people here. 70% of our resources go to this place here. Money and the best manpower tends to go to the ivory tower hospitals. But not tertiary, not secondary, not primary. I'll talk about zero-level care. And what is zero-level care? Zero-level care is where we change the whole equation. I've written a paper on this, on community care, where it looks like we now encourage people to self-care. And I don't know what right word to use. I use a mountain of health. We push them away from getting ill to a mountain of health. This is work from Tom Ferguson in early 1990s, talking about how we should change our medicine. He was talking about information age, but I think it's basically how medicine should change. We move from doctors being at the top to doctors being at the bottom, and we are no longer the people who tell you what to do. We work as facilitators and partners. We form a lot of self-help networks. We encourage individual self-care. And I think this is the way that we need to go forward with health, that our primary role as a healthcare professional is to encourage individual to be kept well, and that includes a mother and a child and a father as well. And similarly, if you are an individual listening to it who's not a healthcare professional, your primary goal in life is to actually remove all your risk factors that make you ill and actually improve the quality of your care of your life. I'd like to end with this statement. Children are our present treasure, not our future. Too many people talk, oh, children are our future. No, they are our present treasure. If we don't do something for them right now, I think that, we won't have them in very good health in the future. Thank you very much. Betty, back to you.
Anyone with any question, please share with us. Let me just continue with mine. Okay. First, I like to think that after your talk, 3 words actually cause all the problem in children. Adults, okay, greed and selfishness, which again boils down to adults. So you have actually presented all the problems that are not so much related to illnesses, but that are very real in this current problem. And
Betty, let me tell you that if we address this problem, that mortality line, which I show you, which has been flat for the last 20 years, will more than half. We may drop it by 75%. So I think that I'm actually talking about health problems that are unrecognized. I wrote a Rancangan Malaysia 12 paper on this, which is in that first link I gave you, and maybe worth looking at it. Yes, back to you.
Yeah. First, in healthcare, as a doctor, we say do no harm. But the first 2 of your health problem that is related to children are actually harm that we have brought in by progress, also we think is progress, or urbanization. And in actual fact, it is done so badly. let's give them the benefit of the doubt and not say it's genocide. Genocide, what?
A silent genocide, meaning that
Silent
it's
genocide.
unintentional. We just overlook what's happening to
No,
them.
okay, I think maybe not so unintentional, but but some of it may be. Okay. Unfortunately, tomorrow I may be called up, it doesn't matter. But truly, honestly, I believe you, because you see, I went to help the Orang Asli, okay, by capoing, being your capo, many years ago. And because there was a flood in Kelantan and Terengganu, a very bad flood. So we had to go in by the 4x4. And there was this group, okay, who went in with all the supplies that were given by the kind-hearted people in the urban area, and they sold it. Okay, a teacher was selling a pack of rice, which is like 5 kg to the student, for 30 ringgit. Okay, this is a teacher selling to the student, Orang Asli student, okay, a packet of rice that costs a lot more than the usual. Okay, so yes, I believe that until and unless all of us, every single of us, have good intention for everyone else, irrespective of age, irrespective of race, religion, then only we will come to a state of a level of better health and better life and better thinking. Okay, let me just share screen now. Okay, anything else? Anyone want to ask any question at all? Okay, the other thing is, let's talk about this injury thing that that we see often enough, isn't it?
Yep.
And we have actually caused us more problems than we thought. For example, how do parents, okay, how do we educate parents to watch over their kids?
Betty, for injury prevention, there are three key thrusts.
Yes.
One is enforcement, one is
Yes.
education, and one is environmental change. Enforcement is only good if there's no corruption involved in enforcement. That means you can't corrupt your enforced service. And that's difficult in most countries. So people think of education, but education is a failure. I did once a systematic review looking at all the education measures for injury prevention in the world, and they don't work. Sweden and Finland have got the best programs for education, and they don't work.
Oh, you mean education really don't work?
It doesn't work well. It's not effective.
On parent?
The only work that education does is if a doctor or a policeman says something, then we tend to listen. It's called anticipatory guidance. So if Betty says, hey, where's your car seat? You don't have a car seat. Then the mother might listen. And similarly, the policeman said, hey, why you didn't wear your seatbelt? So maybe for a couple of weeks, the effect lasts only for a couple of weeks, by the way, you might wear a seatbelt. So most people have invested in research basis, most people are invested in environmental change. And what's environmental change? We change our road structure. So instead of broadening our roads, most people are shrinking our roads. So people have invested in public transport system, people invest in speed bumps, people invest in airbags, people invest in the car seats and stuff like that. So that makes a change, rather than anything else. I don't think you can make a change with behavior, with changing the behavior of the driver or changing the behavior of the average person. That data is not good out there. So I wouldn't put money on education.
I see. So let's say, you mean that to say that, for example, okay, let's take the example of this this bicycle lanjak.
Okay.
They're all kids, right?
Yep.
And they are unsupervised, and they were unsupervised in at God-forsaken time, okay? And they were basically, I mean, can the kids be accounted for this
So
problem?
that's a subset. most of our cycling injuries can be changed with two simple mechanisms. One is to what is this? What should I say? Let me think for a moment. One is to put dedicated cycling lanes for our children. That's one. The second one is to have bicycle helmets. But the first is more important. You know,
Okay.
if you don't
I
put
think
in
we are
the dedicated cycling lanes, then I think you are in trouble for the kids not just wearing a helmet. But the bicycle Chllenges kids are different. They first of all probably come from poorer backgrounds,
Yes.
looking for some meaning in life, not having adequate supervision. I think that you got to deal with our poverty and our social needs issue rather than just
Yes.
cycling per se.
Yes. I think if we bring up the level of the standard of living in everybody, then you will find that the education level in the parents and their thinking will change, and therefore the way they look after the child may also change. Yes, you are right that it is
Yeah, some people are working two jobs. They don't have childcare,
yeah, that's right.
So I don't think I'd be too quick to blame these parents, in our society.
Okay, I take your point. Anyone else with any questions? Because you see, Amma, when you project this and the way we speak about it, you and I, and we are quite open and quite so a lot of people may not dare to ask us questions, especially when we say that it's unintentional genocide.
I think, Betty, some people couldn't get in. I just looked at my handphone because I finished talking, and some people said couldn't get the link to get in. So maybe
Couldn't
that's
get a link to get in?
Yeah, maybe we'll sort that out later. It's too
Yeah,
late now
that's right.
anyway.
It's too
Yeah.
late now. So now I want to ask you about when you say you are dyslexic, and I caught that. Can you explain yourself a little bit?
I only discovered this when I went to school, and I was in PJ at that time. My dad moved us all to Klang Valley because he wanted a better education location, and so I ended up in trouble because I struggle with spelling and reading words, and so every recess kena tangkap lah. Kenapa why cannot spell? Why cannot read? Are you lazy? Bodoh ke? Okay, no recess for you. Stay here and you do your spelling and your reading. Huh?
And how old were you then?
I was about 7. You see, I grew up in a family of 4 other kids with a huge library, and they taught me how to read and write. But a lot of it was actually word recognition. That means I wasn't really reading and writing. I'm memorizing a lot of things. When I went to school, then I was in trouble. But the blessing was my father is an educator. He's a teacher's training college. So many of the teachers who teach me know him. So for that reason, I was spared a lot of punishment. And, I struggled. Medical school was a nightmare with all the terms. Thank God for multiple choice. Multiple choice is a lifesaver for me. You can tembak the answer because you recognize roughly what it looks like. But even today, I will make very, very basic mistakes. Like today, I was talking to somebody about the proof in the pudding. I couldn't spell pudding. I tried very hard. Finally, had to Google online with some pudding kind of word, and then Google fixed my word for me. I use Google all the time to check my spellings. Conscience is the word I can never spell and will never be able to spell.
So autocorrect is your best friend.
Of course, but I still make many mistakes, and my wife is my ultimate proofreader if I write a document because I need someone to look at the mistakes I cannot see because sometimes I just don't see them at all. Grammar mistakes, which are actually spelling related grammar mistakes. I'm not that bad, but I've seen children like me. I had one boy who came at standard 2, and in standard 1, he did quite well in class, but actually he had memorized everything. When people were reading, he memorized everything so he could manage. By standard 2, it became too complicated and he failed.
I see.
And then we recognized that he had dyslexia and he was struggling. So dyslexia comes in different components. It's a heterogeneous condition, not homogeneous. Probably between 5 to 15% of the population struggles with some degree, and probably 3 to 5% have a severe element of dyslexia, enough to impair their education capabilities. So for me, the word will start to move, Betty. If I watch the word will start to move on the page, and then I get trapped. the word tastes wrong in my mouth and I feel, oh, horrible about it. I can't read this word anymore. Huh? So I have to read very fast. I read extremely fast as a means to overcome this. But I also make mistakes now because I read the word wrongly sometimes when I read
I
very fast.
see, I see.
So other children have also shared similar kind of dyslexia that I have, but the other children who don't have that kind of problem, they just have a problem even reading numbers and words. They just don't recognize what that symbol means because after all our reading and writing is symbols.
Can I ask you something before I read Dr. Lim Yu Qian's statement? I want to ask, which I find it very interesting, is that this autism, is it a new disease? Because I don't remember seeing so many.
Yeah, there's a lot of conflict about this. I consider it something new that's been growing. I think we've always had autism, but the kind of autism we've had is always very severe kind of autism. Today, we find that it's growing in volume, not just better detection. And I need to talk a lot more. I need to show you data when I talk this and not just talk off the top of my head.
Yeah.
Some people now talk, as I said, that if you watch the growing rate, that it's going to peak at probably 5%. In some countries, it's already 2% of people have autism. People have blamed many different things, but I think no single factor has been found yet. No genetic or environmental factor has been found. I wouldn't be quick to blame parents or screens or busyness of life, but perhaps some degree of societal change has influenced this. But Betty, definitely all of us feel it's growing, and it's predominantly boys. Huh?
Yes. So I was thinking maybe it's a genetic defect.
It could be, but nobody's found a consistent genetic problem yet. Huh? There's small studies showing folic acid relationship or some genetic relationship, but it's not uniform across the board. Yeah.
Okay, Dr. Lim says that progressive measures often faced with public criticism. Mandatory child care car seats, banning of public smoking, school for refugee students, sex education introduced by previous PH government all came under fire. Ultimately, okay, this is a very, sorry, Dr. Lim, this is a very political kind of statement. I think
it's okay, Betty. I think let me help answer.
Yeah,
I think
that's right.
health and politics are closely linked. It's not possible because politicians are the one who dictate healthcare policy, and so it's important that we influence political decisions. I think what we need to do, Lim, is to try and get governments to see the benefit of having these things. That means the benefit of putting in mandatory car seats in terms of reduction. So quite often I talk in terms of economics. Like when I put in the hypothyroid screening program for the country, I talk health economics and say, this is the amount of money you are potentially going to save if we spend this much of money. And that's the kind of thing that, healthcare, that politicians can hear, that ministers can hear. And I think that's the kind of argument, that refugees, for example, if we help refugees, we actually get a workforce. Our workforce is shrinking. We need a workforce. And so it's
our workforce is shrinking, but if you do have people who are interested in trafficking foreign workers, then they won't worry about this workforce, right? They make money.
And recently we still remain on a lower tier for trafficking. Very sadly, the trafficking report just came out this week, and we are on a lower tier, Malaysia, because we still considered that people trafficking is a problem in our country. Yeah? There's another one by Cheryl Chong.
Yes.
What can us primary care doctors do to tackle these issues that have been brought up? I think, Cheryl, what I suggested, first thing is to change yourself, be aware of this, change your own lifestyle, in terms of how you look at. When I talk to medical students about injuries, I tell them to think about one area in your life you're going to change, one area you reduce injury risk to yourself, whether you're buying a smoke alarm for a building, or whether you're buying a childproof container for in the house to reduce poisoning, or whether now you're buying a car seat. I think one of the best wedding gifts you can give somebody is a car seat. Okay, or a pregnancy gift, it's a car seat, okay, that you can give them. So I think that's the first step, is to become aware of these problems and to tackle them in our own life a little bit first. Then I think you reach out, and you should reach out to groups that are working on these areas. And there are groups working on these areas, and they would think, people like the Citizen Initiative, the Public Health Association in Malaysia, and so on, and people. The third thing is read the data, write, get involved, do your own research, we need more people to speak up in the press. I've written about drowning about 6-7 times, but there's hardly a drop in the bucket. We need a lot more people to talk about, hey, drowning is a huge problem in our country, so we need to do things like that. Okay, and then ultimately, of course, we need to sensitize everyone so that we vote in the kind of people, the politicians that we want to make healthcare change possible for us. And I'm not talking just about these issues and many other issues that we need change. We need primary care to be the primary focus of any health ministry. That must be the focus, not hospital.
Remember, Amar, just now you said that I think one of your slides, you said that we not only need speech therapists, but we need somebody who can provide speech therapy support, physio. Yep. Don't you think that our primary care doctors, and now we have so many doctors, aren't they the best people to be trained to do all this?
Yeah, that's possible. In fact, one Canadian professor who listened to me, he actually started a college for this. So other people are taking up our ideas, but we're very poor at taking up our own ideas. So it's called a transdisciplinary therapist. In fact, that's what a primary care person is. The transdisciplinary therapist. I'm very wary of subspecialists because subspecialists know a lot about one small area.
Okay, thank you.
Yeah. Hey, don't forget, I've got a subspecialty, but I did my subspecialty in public health. I did my subspecialty in community pediatrics. No, I did mine in community pediatrics. So I could become broader in my subspecialty.
I thought that you were neonatologist.
No, I'm not. Yeah. So I think that, Cheryl, what we need to do is, get engaged with the community. Cheryl, one of the most powerful things you can do is start an NGO that does work. And you can become the advisory role to tell them what the right thing to do, and people will do work, because they recognize it's important thing. I've started about 12 NGOs, and it's phenomenal what these organizations can achieve.
But NGO work is not easy, right?
No, it's not. It's not easy, and you've got to choose the right kind of people to come in. Very important. Not people who are self-serving, but people who want to serve the community. Yeah?
And that is also more difficult than running the NGO yourself.
Of course, choice. That's why you got to choose people at the beginning very carefully here.
Okay, since we do not have any more questions. Okay, there's one. Okay, Cheryl just says thank you. And so with that, we'd like to thank you, Amar. We'll meet you again next week on another interesting topic. And I think it's on medical legal, right?
Yes, child protection, medical legal, how to operationalize our Child Act and use it. Yep. And
it's so in the next 3 talks, we are all touching on medical legal because we also have PS Ranjan coming in. So
very good man. Yes.
Yes. Not many doctors would like to hear from him though. Okay. Thank you very much, Amar. I'll see you next week.
Take care, Betty.
Okay.
Bye-bye.
Okay. Let me WhatsApp you then. Bye bye.
Okay,
Thank
bye-bye.
you.